good morning for everyone. My name is Felipe Lozano. I'm a fellow of clinical cardiology at the University of Antioquia. It's an honor for me and for our cardiology group to introduce today Dr. Mitchell Kittheson. She is a cardiologist, a professor of medicine at Sinai Medical Center, and she's also a director of postgraduate medical education in heart failure and transplantation. And no more important, she's one of the main authors of the recent American Society of Cardiology guidelines on preserved heart failure. She will talk to us about some key aspects in the therapeutic and approach and diagnosis of the patient with heart failure with preserved ejection fraction. And doctor, go ahead with your presentation, and thanks again for accepting our invitation.
Thank you so much. I'm delighted to have the opportunity. So let's dive into heart failure with preserved ejection fraction. And let's see here. I have no disclosures. So as you mentioned, there is a recent expert consensus decision pathway on the management of heart failure with preserved ejection fraction. And the two most important publications upon which this talk are based are shown here: the 2022 guideline for the management of heart failure, as well as the expert consensus decision pathway of HFpEF. Now, I was honored to be a member of the writing committee for the heart failure guideline and the chair of the writing committee for the expert consensus decision pathway. Now, everything is more interesting when we talk about a patient. So let's begin with a case. Let's talk about a 72-year-old woman who presents with a 2-week history of shortness of breath. She has hypertension, paroxysmal atrial fibrillation, and osteoarthritis. Her medications include rivaroxaban, chlorthalidone, amlodipine, and ibuprofen as needed for knee pain. On examination, BMI is elevated at 31, heart rate 68, blood pressure 142/88, JVP 10 centimeters water, lungs clear, heart regular with an S4 gallop, and she has 2+ edema. Her echo shows mild increased LV wall thickness with a septum posterior wall of 1.4 centimeters, EF 60%, mild aortic stenosis with a mean gradient of 1.6, valve area 1.9 centimeters squared, and mild pulmonary hypertension with an estimated right ventricular systolic pressure of 40 millimeters mercury. So when faced with a patient who presents with dyspnea and edema, it's first important to construct a differential diagnosis. I think that's one of the greatest challenges in medicine, is working backwards. In medical school, we learn about diseases, but patients don't present with diseases. They present with symptoms. So learning the art of working backwards from symptoms to diagnosis is something that's very important, a skill we all need to have, but sometimes it's a dreaded skill because it can be challenging. The best thing to remember is organize your etiology of diseases by anatomy and pathophysiology. So in this case, if we think about dyspnea, we organize it into the sources of dyspnea. There may be a cardiac source, there may be a pulmonary source, or there may be another source. So let's think about cardiac sources of dyspnea. The problem may arise in the heart muscle, a cardiomyopathy, the heart arteries, coronary artery disease, the heart valves, valvular disease, the pericardium, or the electrical system, arrhythmia. So you break down the system by anatomy. The next place, of course, dyspnea arises is the lungs. And again, anatomically, you think about airway disease, parenchymal disease, pleural disease, or vascular disease. When it comes to other sources, we think about other components of the sensation of dyspnea. There could be anemia, so there's decreased oxygen carrying capacity of the blood. There's neuromuscular disease, so the lungs are unable to expand. There could be deconditioning, which leads to the sensation of dyspnea, or anxiety, a more central source. Similarly, we should work through the differential diagnosis of edema. And as cardiologists, of course, will be focused mainly on excluding or confirming a cardiac source. So moving on to edema. Again, think about anatomy and pathophysiology. So the source of edema may be increased capillary hydrostatic pressure or decreased capillary oncotic pressure. And the source of increased capillary hydrostatic pressure may be cardiac, the muscle, the valves, the pericardium. It may be cirrhosis with portal hypertension, kidney failure, or other anatomical issues like venous insufficiency, obstruction, thrombosis, pregnancy, or medications that result in fluid retention or vasodilation, such as calcium channel blockers, NSAIDs, or steroids. There can also be decreased capillary oncotic pressure, which may come from decreased protein intake, like malnutrition, decreased protein production, like cirrhosis, or protein loss manifesting from malabsorption or from GI losses or nephrotic syndrome, kidney losses. And again, if you're looking for a unifying cause of edema and shortness of breath, often the cardiac system narrows your focus. So taking into account our 72-year-old woman with dyspnea and edema, what's the most likely diagnosis? Cardiac amyloidosis, heart failure with preserved ejection fraction, hypertrophic cardiomyopathy, aortic stenosis, pulmonary arterial hypertension? Well, I'm going to convince you that it's heart failure with preserved ejection fraction. Why are all these others less likely? Well, cardiac amyloidosis is always possible. We'll talk about this in a few slides. Hypertrophic cardiomyopathy, however, is defined as an unexplained increase in LV wall thickness. Hers isn't that thick, actually, and explained by hypertension, and 72 is a bit old for diagnosing HCM. Aortic stenosis, but her aortic valve isn't that bad on exam or echocardiogram, doesn't support that as the cause of her symptoms. And pulmonary arterial hypertension, in turn, her pulmonary pressures are not that high. She doesn't fit the typical demographic. So when you're thinking about a diagnosis of heart failure with preserved ejection fraction, think about the universal diagnosis of heart failure. The universal diagnosis of heart failure requires two criteria: symptoms and or signs of heart failure caused by a structural and or functional abnormality, corroborated by at least one of the following: elevated natriuretic peptides or an objective evidence of cardiogenic pulmonary or systemic congestion. The two of these together meet the diagnosis, the universal definition of heart failure. Regarding HFpEF specific considerations, of course, if we're looking for a structural and or functional abnormality, in HFpEF, the EF will be 50% or greater. If we're looking for the corroboration, remember, the patients with HFpEF will have lower levels of natriuretic peptides relative to HFrEF for a given elevation in left ventricular end diastolic pressure. So we can't hang our hat completely on the natriuretic peptides. In addition, remember that BMI is inversely associated with natriuretic peptide levels. So if you have two patients with the same elevation in left ventricular end diastolic pressure, the one with the higher BMI will probably have a relatively lower natriuretic peptide level. And because high BMI is also prevalent in HFpEF, that can lead to lower than expected natriuretic peptide levels. So let's focus on the symptoms and or signs of heart failure, because that would be the first step for your diagnosis. So yes, of course, dyspnea and edema are on the list, but I like to organize by the Framingham criteria. Came out many years ago, but still very valid. So the major criteria: paroxysmal nocturnal dyspnea, orthopnea, elevated JVP, RALS, S3 gallop, cardiomegaly, pulmonary edema. The minor criteria would be bilateral leg edema, nocturnal cough, dyspnea on exertion, hepatomegaly, pleural effusion, or tachycardia with a heart rate above 120. In this patient we talked about, she has an elevated JVP, edema, and dyspnea, and that meets the Framingham criteria, where you need either two major or one major plus two minor criteria to make the diagnosis. If you're thinking about HFpEF, the next thing you want to ask yourself is, does the patient have typical demographics or associated conditions? What are the typical demographics or associated conditions? HFpEF generally occurs in patients who are older, female, with hypertension, atrial fibrillation, diabetes, coronary disease, obesity, and kidney dysfunction. And in the brief vignette I gave you, this woman already has many of these associated conditions and typical demographics. And even though the echocardiogram may show a preserved ejection fraction, it doesn't mean the echo is normal. There can be increased left ventricular wall thickness, increased left atrial size. There can be diastolic dysfunction. While diastolic dysfunction on an echo is neither necessary nor sufficient for the diagnosis, there may be typical abnormalities in the mitral inflow velocity, Doppler tissue imaging, and pulmonary venous flow. And finally, there can be an elevated estimated RVSP, and this woman, in fact, met some of these criteria. Now, if all else fails, one could do a cardiopulmonary exercise stress test looking at the peak VO2 or maximal oxygen consumption, or a right heart catheterization with exercise to look at the change in the left-sided filling pressures. But I consider those mainly research tools. It's unclear how they truly change management in a clinical setting. What I find more helpful, in fact, would be the H2F-PEF score. The H2F-PEF score is a really easily accessible, using readily found clinical variables as part of routine practice, and gives you a probability of HFpEF. So it's heavy, BMI greater than 30 is 2 points, hypertensive, 2 or more antihypertensives is 1 point, atrial fibrillation, paroxysmal or persistent is 3 points, pulmonary hypertension as measured on Doppler echo with an estimated PA systolic pressure over 35 is 1 point. Being elderly, age over 60 is 1 point. And filling pressures with a Doppler echo E to E prime ratio over 9 is 1 point. So if I go through this patient, she has an elevated BMI, is on 2 or more antihypertensives, has atrial fibrillation, estimated elevated pulmonary artery pressures, and is older. That gives her a score of 8, which gives her, in fact, an over 95% probability of HFpEF. Seems pretty simple, and many times it is simple, but I want to show you a different case to illustrate the pitfalls of diagnosis. So what about this patient? A 72-year-old woman, same age, same sex, now presents with a 2-month history, and she has a more indolent course with fatigue and shortness of breath. She no longer has hypertension, she no longer has osteoarthritis, but she does have bilateral carpal tunnel syndrome, spinal stenosis, and peripheral neuropathy. Her medications still include rivaroxaban and metoprolol, but now she's on gabapentin. She's no longer on antihypertensives or NSAIDs. On exam, she is not obese. She is not hypertensive. Her JVP is a bit higher, and her echo looks exactly the same. So what's the most likely diagnosis for this patient? And let's see if I can convince you that it's in fact cardiac amyloidosis. So let's start by doing her H2F-PEF score. Well, she has atrial fibrillation, pulmonary hypertension, and she is older. That gives her a score of 5, an 85% probability of HFpEF. But is it HFpEF? So what this exercise is meant to illustrate is that HFpEF is a diagnosis of exclusion, which can be the hardest diagnoses to make. And when you think about your differential diagnosis of dyspnea, edema, meeting criteria for the universal definition of heart failure in the context of a preserved ejection fraction, don't forget other things like restrictive cardiomyopathy, hypertrophic cardiomyopathy, valvular heart disease, right heart failure, obstructive lesions, pericardial disease, high output heart failure. And it's important to assess for treatable or reversible causes, because you might find a diagnosis for which there is disease-directed therapy to improve your patient's quality of life and survival. Now, an echocardiogram is useful to rule out most things, along with your history, an MRI in some cases, as well as a right heart catheterization. Some of the clues that it's not garden variety HFpEF might be a younger patient without typical comorbidities, more progressive symptoms as opposed to intermittent exacerbations, and a relatively low QRS voltage on ECG. These patients often have increased left ventricular wall thickness from hypertension, but is it truly muscle increasing the LV wall thickness, manifesting as increased voltage on the ECG? Or is it in fact infiltration into the muscle, causing the increased wall thickness, in which case there might be not by definition low QRS voltage, but relatively low or discordant. And so really the restrictive cardiomyopathy, the infiltrative cardiomyopathy, is what you want to make sure not to miss in this population. So the diagnosis of HFpEF is a process. Your patient has dyspnea and or edema. You'll look for non-cardiac sources by running through your differential diagnosis. You'll apply the universal definition of heart failure. You'll exclude those heart failure mimics. You'll assess your HFpEF score before you assign your patient a diagnosis of HFpEF. And this is so hugely important because you truly want to make sure that you have the right diagnosis for which there is appropriate treatment. So to summarize, patients with dyspnea and or edema, you apply the universal definition of heart failure. You ask yourself, are there non-cardiac mimics? Is there a primary non-cardiovascular entity causing symptoms? Then you say they have congestion primarily from kidney disease, liver disease, or chronic renal insufficiency. Or is there a HFpEF mimic? Does the patient's presentation warrant a specific diagnostic assessment? Do they have heart failure attributed to an infiltrative cardiomyopathy, a hypertrophic cardiomyopathy, pericardial disease, valvular disease, or high output failure? That does not mean that every patient needs an exhaustive diagnostic assessment. It means you need to rely on your history and physical exam to lead you down a potential path towards additional testing individualized to the patient sitting in front of you. And if you've convinced yourself there is no mimic, either by your H&P or additional testing, then you can give the patient a diagnosis of HFpEF, but you should identify relevant comorbidities contributing to their presentation that warrant treatment. HFpEF associated with the common comorbidities of hypertension, diabetes, atrial fibrillation, obesity, coronary disease, kidney dysfunction, and treat accordingly. Now, the most important, I think, on this list to not miss is cardiac amyloidosis and infiltrative cardiomyopathy. So let's take a detour because this is such an important item on our differential and speak briefly about cardiac amyloidosis. So as you know, cardiac amyloidosis is a condition where there's a protein that is produced naturally in the body that, for reasons we don't understand, decides to infiltrate the myocardium, resulting in a restrictive cardiomyopathy. The two most common places it will come from are the immunoglobulin light chains, that would be AL cardiomyopathy, or the TTR transthyretin protein, that would be ATTR cardiomyopathy. And the TTR protein in turn can have one of two sources, either a mutation in the gene, that would be the variant form, ATTR-V cardiomyopathy, or the wild type gene. Now, it's important to remember that this amyloid protein just doesn't infiltrate the heart. It can go other places as well. There can be a neuropathy, a nephropathy unique to AL, gastrointestinal involvement, and orthopedic musculoskeletal issues. And those can often be the key to the diagnosis. When it comes to amyloidosis, remember to have a high index of suspicion because your heart failure symptoms are simply the tip of the iceberg. And it's important to remember what lies beneath. These patients might have more nonspecific symptoms like fatigue, other cardiac findings like atrial fibrillation, AV block pacemaker. Interestingly, when it comes to aortic stenosis or HFpEF, in series of patients with severe aortic stenosis admitted for transcatheter aortic valve implantation, about 15% have underlying concomitant cardiac amyloidosis. Similarly, in series of patients admitted with heart failure with preserved ejection fraction, ostensibly, further testing demonstrates that about 15% actually have cardiac amyloidosis. These are important clinical clues, as is increased LV wall thickness with discordant, not necessarily low, but disproportionately low QRS voltage. The neurologic findings, there can be a sensory neuropathy with paresthesias. There can be autonomic dysfunction that manifests most commonly as orthostatic hypotension with intolerance to vasodilators. So you might have an elderly patient with mild hypertension for which you prescribe a vasodilating antihypertensive like amlodipine or lisinopril, and the patient comes back a few weeks later with symptomatic hypotension orthostasis. That could be a sign of autonomic dysfunction. And the orthopedic musculoskeletal symptoms, commonly carpal tunnel syndrome, especially bilateral, presenting at an older age, requiring surgery, and spinal stenosis. So when we look back at that patient, it jumps out at you, the seemingly disparate findings that lead to a satisfying, unifying diagnosis. The indolent course, the musculoskeletal / orthopedic and neurologic symptoms, the lack of comorbidities like obesity, the unexplained mild LV wall thickness without hypertension. Putting it all together, you're not going to miss a diagnosis of cardiac amyloidosis. So let's track back now to HFpEF and talk about treatments. Which of the following is recommended for the treatment of HFpEF? Lisinopril, furosemide, carvedilol, isodonyl hydralazine, digoxin. Well, the answer, of course, is furosemide. And as we'll discuss, many of these other therapies can play a role in the management of heart failure with reduced ejection fraction, but they have been applied and tested in heart failure with preserved ejection fraction with little success. And I think that really comes down to is the fact that in contrast to HFpEF, heart failure with reduced ejection fraction is a triumph of translational medicine, where our understanding of little molecules has translated into medications to help our patients feel better, stay out of the hospital, and live longer. So when we think about heart failure with reduced ejection fraction, we can think about the sympathetic nervous system, the renin-angiotensin-aldosterone system, the natriuretic peptide system, and recognize that blocking or promoting these systems can in fact lead to important therapies for our patients. Unfortunately, these don't come into play to the same degree in HFpEF, which is why attempting to use HFrEF therapies has, with almost all exceptions, not met with success. So when I think about the pathophysiology of HFpEF, I liken it a bit to the parable of the blind men and the elephant. Our understanding of HFpEF pathophysiology is truly in its infancy. And so in this parable, there are 6 blind men who come across an elephant in a field. And they all approach him from different angles and try to convince each other what an elephant is. And depending on whether they encounter his tusk, his side, his leg, his trunk, his ear, his tail, they try to convince each other that an elephant is a fan, wall, rope, tree, snake, spear. Because the problem is they only see a part and they don't understand how that part contributes to the whole. Similarly, when it comes to our understanding of HFpEF pathophysiology, we understand a lot of the parts. There is diastolic dysfunction with increased myocardial stiffness. There's systolic dysfunction and chronotropic incompetence. There's vascular dysfunction with reduced arterial compliance. There's skeletal muscle dysfunction with decreased oxygen extraction. There's endothelial dysfunction with decreased flow-mediated vasodilation. And there's right heart dysfunction with pulmonary hypertension, tricuspid regurgitation. But to put these into a unifying pathophysiological mechanism from which therapies can emerge has been very challenging. And that's when we think about HFpEF therapies, we have the bad, the good, and the maybe. And when it comes to the bad, it's multiple therapies that have been tried and not worked. Really, anything that was attempted in HFrEF was also attempted in HFpEF, and many met with no success. No success from isodonyl hydralazine, irbesartan, perindopril, statins, digoxin, nebivolol, ivabradine, isosorbide mononitrate, sildenafil, and serelaxin. However, there is some benefit from some of these therapies. We'll talk about spironolactone, candesartan, exercise training, calorie restriction, implantable PA sensors, sacubitril valsartan, SGLT2 inhibitors. And we'll talk about the interatrial shunt device as a potential future option. Now, what does deep phenotyping mean? It means essentially that patients with HFpEF can have different phenotypes really based on those pathophysiologies. Some will have predominantly right heart dysfunction, TR. Some will have predominantly chronotropic incompetence. Some will have predominantly more myocardial stiffness with an elevated wedge in response to exercise. And some will have previously undiagnosed conditions like cardiac amyloidosis. So really, the role of deep phenotyping currently clinically is essentially don't miss amyloidosis, as we've discussed. So let's go on to some of these potentially promising therapies. Let's start with spironolactone, tested in the TopCat trial, about 3,500 patients with symptomatic HFpEF. And there was no difference in the primary endpoint, combined death and heart failure hospitalization, there was in the secondary endpoint of heart failure hospitalizations. And of course, as expected, those patients who received spironolactone had a bump in their creatinine and potassium after receiving therapy. So this would have been the end of TopCat. Very disappointing, no change in the primary endpoint, put it in the back of your mind, a negative trial. But it's important not just to read that sound bite, but to look at the fine print and to look at the fine print of a subgroup analysis subsequently published. So in this geographical subgroup analysis, patients in the Americas were compared to those in Russia and Georgia. Now, half of the patients in this international trial came from Russia and the former Soviet state of Georgia. And they were very different. While the point estimates for heart failure hospitalizations in the Americas was 21 versus 25%, in Russia and Georgia, it was much lower, 2 versus 3%. And also unusual is that typical expected bump in creatinine and potassium seen in patients enrolled in the Americas was not seen in Russia and Georgia. This was highly concerning. Were the patients in Russia and Georgia really HFpEF patients with such low event rates? Were they really given spironolactone, given the lack of bump in creatinine and potassium? This speaks to potentially nefarious trial doings, and no one will repeat this multi-million-dollar trial again. So really, we're left with a very unsatisfying resolution. We are all taught that subgroup analyses are inherently hypothesis generating because they do not follow randomization. However, I truly believe there's a signal here that there is a benefit, and the trial itself was clouded by the inappropriate enrollment of patients in Russia and Georgia. Unfortunately, the guidelines, based on the lack of improvement in the primary endpoint, have given spironolactone a weak indication, may be considered to decrease hospitalization, particularly among patients with EF on the lower end of the spectrum. But let's move on to something more promising. Let's talk about the SGLT2 inhibitors. We have Emperor Preserved and Deliver, both about 6,000 patients, both with symptomatic HFpEF, randomized to empagliflozin or dapagliflozin versus placebo. In both trials, met their primary endpoint, which was a composite of death and heart failure hospitalization. The first two trials to ever meet their primary endpoint in HFpEF, that's cause for celebration. And while there was a non-significant difference in death, there was a significant reduction in heart failure hospitalization or worsening heart failure, and also a demonstrated decrease in the rate of decline of eGFR. So this is hugely exciting. Now we have two consistent trials showing us that the benefit of SGLT2 inhibitors exists across the spectrum of ejection fraction in HFpEF. In fact, it's the first medicine to truly straddle that boundary of pathophysiology, probably because no one's exactly quite sure how it works, and it works both for HFrEF and HFpEF. Now, the guidelines gave this a class 2A indication, can be beneficial, not the strongest class 1. That may have been because at the time the guidelines were published, the only evidence was from emperor preserved. Now, with the benefit of Deliver, it remains to be seen what subsequent versions of the guidelines will say regarding SGLT2 inhibitors. But there's no question it is our strongest evidence-based medication for the treatment of HFpEF. Now, what about the ARNIs? So ARNIs were studied in Paragon HF, almost 5,000 patients, symptomatic HFpEF, no difference in the primary endpoint of cardiovascular death and heart failure hospitalizations. And secondary endpoints, the outcome of heart failure hospitalization was almost significant, p-value of 0.056, but almost is not the same as significant. So we really have to say it was a negative trial. And when we look at the subgroup analyses, we see for those patients who were women or had their ejection fractions below the median of 57%, lower end of the spectrum, there was a signal to benefit. But again, subgroup analyses are hypothesis generating. So because it is a negative trial with some signal of benefit on subgroup analyses, it gets a class 2B weak indication from the guidelines may be considered. Similarly, we have candesartan, the angiotensin receptor blocker, tested in Charm Preserved. This was pretty exciting. Charm Preserved showed quite a dramatic difference in heart failure hospitalization. However, subsequent meta-analyses, in fact, did not reproduce this, and there was little or no effect of ARBs on mortality or heart failure hospitalization, which is, again, why ARBs have a weak indication. So that takes us through the medical therapy of HFpEF, but there are also the non-pharmacological interventions that may benefit patients. So let's talk about those. Let's talk about exercise and weight loss. And here are two cardinal studies to keep in mind. The figure on the left is 100 patients with HFpEF, older, average age 67, heavy, BMI 39. They were randomized to receive either calorie restriction, reduction of 400 kcals a day, or aerobic training 3 times a week, or both. And you can see, based on that blue line, that's patients who receive both, their change in peak VO2, of course, that's a measure of functional capacity, was improved with either aerobic training or calorie restriction, and improved the most when patients got both. The other bar graph there on the right shows the KCCQ overall score, quality of life measure, and it shows that while aerobic training didn't seem to improve quality of life much over control, certainly calorie restriction had a major impact on quality of life. In another meta-analysis looking at the impact of exercise, that's shown in the forest plots on the right. This is from 6 randomized trials. Supervised exercise training leads to better exercise tolerance and better quality of life. So really, no question here, this works. And we have multiple additional trials that also show this as well, that when it comes to interval training, endurance or resistance training, calorie restriction, gastric bypass even, the outcomes are improved. Peak VO2, quality of life, and echo parameters. Unfortunately, at least in the United States, cardiac rehab is not covered by insurance if your ejection fraction is preserved. That's a major detriment, since we know that an intervention that improves outcomes is supervised exercise training. So it is hopeful that in the future that policy will change, but until then, it's about encouraging patients to work on weight loss and/or exercise training to improve their symptoms. What about HFpEF, the pulmonary artery sensor? So the pulmonary artery sensor, which is placed as part of a right heart catheterization procedure, very small, less than the size of a dime, was studied in the Champion HF trial. 550 patients, 50% with HFpEF, randomized to placement of the cardiomems versus a control group where the information was not available. And in fact, there was a significant reduction in heart failure hospitalizations. Interestingly, these patients, why did this thing work? It's not a therapeutic maneuver. It is a diagnostic maneuver. You are getting information about pulmonary pressures, which may trigger a response in clinicians to doing additional therapy. So why is this a good thing? Well, it turns out that when clinicians had access to this information, they were more likely to change medications, an average of 4 versus 2 medication changes. So is it the placement of this device that is helpful, or is it just that this device helps clinicians overcome therapeutic inertia? You know, the other issue with this trial is the issue of blinding. Because one group had an intervention with more aggressive therapy, it's not clear if it's the device that truly made the difference, which is why the guidelines give it a relatively weak Class 2B indication, and the usefulness to reduce the risk of subsequent heart failure hospitalization is uncertain. Now, the final intervention I want to talk about for HFpEF are the interatrial shunt devices. So the principle behind these devices is that patients with HFpEF have stiff hearts. So that means they have, for small changes in volume, they will have big changes in pressure. That means that if they have increased blood flow, like with exercise, that will lead to increased left-sided filling pressures transmitted back to the lungs, causing dyspnea. So that's why patients with HFpEF have such significant dyspnea. Now, this can be improved, one would assume, theoretically, by putting a pop-off valve in the left atrium. So let's help the left atrium deal with the extra blood and filling pressures that happen with exercise by putting a shunt to the right atrium to offset some of this and unload the left side of the heart. So this was the reduced lap HF trial, which tested that theory by taking 44 patients with symptomatic HFpEF, taking them to the cath lab, and then looking at their wedge pressure with exercise, and it rose with exercise, that's the red line, and then put in the interatrial shunt device and saw what happened to the wedge with exercise. And in fact, based on the blue line, when the shunt device was in place, the wedge was lower. So this is all well and good theoretically, but you really want to know about functional status, exercise tolerance, quality of life, heart failure hospitalizations, mortality. That's the stuff our patients are going to care about, not the theory. And in fact, the first trial on this was the reduced lap HF2 trial. This was many more patients, 626, symptomatic HFpEF. They had to have a wedge 25 or more during exercise to enter, meaning they phenotyped these patients very well. But sadly, the results were completely disappointing. We're based on patients who had a sham procedure. There was no difference in death. There was no difference in hospitalization. And probably most disappointing, there was no difference in quality of life. In a subgroup, there was a signal potentially for a sex-based difference in interaction by sex, but ultimately we have to say the trial was negative. And it's hard to know if it was negative because of the device, if it was negative because of the pathophysiology. In fact, there's the Relieve HF trial ongoing with a different device. It's enrolling 500 patients, and we should await the findings to have a better sense of where this fits in our armamentarium. So when we think about what the guidelines tell us, diuretics have the strongest indication, titrate them to symptoms. SGLT2 inhibitors have the strongest randomized evidence, and everything else was sadly a bit disappointing, though as I mentioned, I truly do believe the subgroup geographical analysis of the TopCat trial and put a lot of faith in spironolactone. I also want to point out the level of evidence of much of what we do in HFpEF. C is limited data, or C, expert opinion. And when it comes to B-R, that's randomized trials, most of the randomized trials are disappointing and lead to weak indications. So when you think about HFpEF treatment, first line should be the SGLT2 inhibitor. That is the best medication you can give your patient with HFpEF. If patients have fluid retention, they should get a loop diuretic. Think about the mineralocorticoid antagonist, especially for women or men on the lower end of the spectrum. Think about the ARNI. Think about an ARB for those who cannot take an ARNI. But for me, the most important agents are the SGLT2 inhibitor and the MRA. Now, as I mentioned when we started, when you diagnose someone with HFpEF, you're not done. You must remember the interplay of comorbidities, the hypertension, diabetes, and obesity that not only contribute to HFpEF, but contribute to the other associated comorbidities like sleep apnea, chronic kidney disease, coronary disease, and AFib. And managing these can also improve your patient's quality of life and outcomes. So taken in turn, for your patients with atrial fibrillation, your rate versus rhythm control strategy should be guided by symptoms. You avoid aggressive rate control due to low stroke volume. They may need a beta blocker or non-dihydropyridine calcium channel blocker plus digoxin if needed. Anticoagulation unless contraindicated because their CHAD2 VAS score is generally going to qualify based on age, sex, and hypertension and heart failure. Then it comes to hypertension. Your goal would be less than 130/80. Of course, quality of life matters. And for those patients who are of advanced age with symptomatic orthostasis, you may want to run them higher for safety. Your agents may include the diuretic, ARNI, ARB, MRA, all very useful for hypertension with additional benefit in HFpEF. And of course, evaluate for secondary causes, predominantly renovascular disease when appropriate. When it comes to coronary disease, your testing and intervention will be guided by the presentation and symptoms, and you'll put them on medical management, including aspirin, high-intensity statin therapy per relevant guidelines. When it comes to diabetes, you'll target an A1C less than 7 to 7.5%. SGLT2 inhibitors should be first line, and the GLP-1 receptor agonists for your patients with obesity or high risk for atherosclerotic cardiovascular disease, as more and more trials are indicating additional benefit. And avoid those agents with poor outcomes or heart failure caused by those agents, allogliptin, saxagliptin, and the thiazolidine diones. When it comes to chronic kidney disease, RAS inhibitors and SGLT2 inhibitors may slow progression. And remember, an ARNI is safe if your eGFR is over 30, SGL2 if your eGFR is above 20. So don't be scared to use them or to collaborate with your nephrologist for comfort if the indications are in question. Sleep apnea. Remember that symptoms and risk factors should prompt polysomnography. Symptoms such as daytime somnolence, nighttime snoring, daytime headaches. You can refer to a sleep specialist and encourage weight loss. And speaking of weight loss, it does lead to improved hemodynamics, functional status, and quality of life in patients with HFpEF, exercise and calorie restriction, and think about semaglutide and tirzepatide as potential options. The bottom line when it comes to HFpEF is that it takes a village. Much like raising a child, taking care of a patient with HFpEF requires collaboration from multiple people on the care team. So we think about the skills and members of the care team. It'll involve diagnosis and ongoing monitoring, prescription titration and monitoring of GDMT, patient and caregiver education about prognosis and treatment, lifestyle modifications and ongoing monitoring of progress, psychological support and prescription assistance, coordination with primary care and specialists, and referral to palliative care. The members can include physicians, specialists in geriatrics, comorbidities, palliative care, advanced practice professionals, pharmacy, social work, nursing, and home care. So my take-home messages for you. HFpEF is a diagnosis of exclusion. Echocardiogram helps, but the history is also really important. Don't miss amyloidosis. Implement promising therapies, SGLT2 inhibitor, of course, and my plug for the mineralocorticoid antagonists. And remember to use your village of specialists in the comorbidities to optimize the care of your patients. Thank you so much for your attention. I'm happy to take any questions in the time remaining.
Dr. Kittheson, I'm very pleasure and thank you so much for your excellent lecture. We got some questions in the audience. The first one is that if we are reading several of the consensus that have emerged on this subject, some of the authors raise the possibility that maybe the use of that invasive strategies in patients where the information of the clinic or some clinics are inconclusive, they say that maybe they underused. What is your opinion about this question? And do you think what will be the patient or the characteristics of the patient that require an hemodynamic evaluation?
So I think you're getting at using something like an exercise right heart catheterization to make the diagnosis. It's a good question. I think you have two options when a patient presents to you with dyspnea edema and you've convinced yourself they have heart failure. It's the heart's fault. It's not the kidney or the liver or something else. And then you've convinced yourself it's not something like amyloidosis, a diagnosis you don't want to meet. I see the question you wrote down there. I'll answer this one first. When would you go for something like a right heart catheterization to try to cement down the diagnosis? I rarely put patients through an exercise right heart catheterization. I'm more likely to empirically give them the SGLT2 inhibitor and the MRA and see if they feel better before going to an invasive test that I'm really not sure where it fits in a clinical as opposed to research algorithm. Regarding the question that just went into the chat about exercise training and a cardiac rehab program, absolutely 100%. I think this is hugely important for patients. I think it's a great failure of the United States healthcare system. Well, there's many failures that we don't cover cardiac rehab for patients with heart failure with preserved ejection fraction. You must have a reduced ejection fraction with heart failure to be allowed to have insurance pay for it. So here, I cannot send my patient with HFpEF to a supervised exercise training. So I do tell them to do it on their own. And you know what? It's difficult, not because I'm worried about safety. I mean, they're not going to decompensate in a dangerous way through exercise. I worry more about the motivation to sustain a program. So depending on the patient and what I gauge as their level of interest or motivation, I may start by just telling them, start walking 10 minutes a day, ramp yourself up to 30 minutes a day. There are guidelines from the American Heart Association that say 150 minutes of aerobic exercise a week is ideal. So I tell them to try 30 minutes of walking 5 days a week to be your new goal. Once you're able to achieve that, you start working on speed and inclines. So try to themselves work on that program. For those who are more motivated and perhaps have resources and access to a gym, I tell them just Google the phase 2 cardiac rehab components and do it on your own. Do the treadmill, do the bike, lift the light weights, go through the structure that's available online to any interested person. You don't have to measure your heart rate or blood pressure with exercise. It's not that important. Just go by your symptoms. So that's the type of advice I give people, and depending on their resources and motivation, how much they can incorporate exercise into their clinical practice.
Thank you so much for that answer, Dr. Kittheson. I have another one respecting with the BMP, because when you see the guidelines and the consensus, there is no text supporting the use of different cutoff points of this BMP. And as we know, for example, with the age, it's increasing in age, the BMP is increasing too. So many other authors consider that we can use or we must use a different cutoff points of the BMP reflected with the age. What is your opinion about this? Because in the recent consensus, there is not anything texting supporting this opinion.
Yes, no, great point. I think it really speaks to the pitfall of the inappropriately low or relatively low BNP, the natriuretic peptides in patients with HFpEF. And I think that is why the H2FpEF score does not include BNP. Now, there is the HFA-PEF score, which we talk about in the guideline, which I did not talk about in my talk because it me is very complicated, harder to be accessible to the clinician with the patient sitting in front of them. It does include BNP and many other parameters. My sense is this, because it can be falsely elevated, falsely reduced, you don't want to dissuade yourself from a diagnosis based on a natriuretic peptide. So I personally don't check BNPs as part of my clinical practice when attempting to diagnose HFpEF, because if it's low, that doesn't help me. Now, I suppose you could argue if it's high, that often makes me wonder if I'm missing something like amyloidosis, because that's much more like an infiltrative disease is much more likely to have an elevated BNP. But I think there are so many other useful parameters of the demographics and the associated comorbidities that assist me that it is not something I routinely check in practice. I truly, and we know based on patients with HFrEF, that while it is useful perhaps for prognosis, check it on admission, check it on discharge, when someone is admitted with decompensated heart failure, we know that serial assessments of BNP does not improve outcomes. So really, as a heart failure cardiologist, I almost never check it. I think the greatest utility, in fact, is for non-cardiologists, those working in emergency departments. When the patient shows up with COPD and they're not sure what the diagnosis is, it may point them in a direction. However, even for them, there's a pitfall if you have an obese person with HFpEF. So I truly believe that of all the biomarkers we have, that when it comes to heart failure, particularly HFpEF, is not useful.
Thank you very much, doctor. And the last one question is about something that we have to challenge in the treatment of these patients is that amyloidosis cardiac patients, because as we know and recent information are growing in respect of the treatment that we have to use on these patients, but we know also the limitation with some of them because of they can't tolerate because of some adverse effects of the medication. Well, what do you think may be the main drugs to consider in these patients with amyloidosis, specifically with cardiac compromise?
Yeah. So cardiac amyloidosis, absolutely. Definitely can be a mimic of HFpEF. You must make sure you have done your due diligence to exclude it based on history, physical, and/or ancillary testing if your history and physical point you in that direction. And if the patient has cardiac amyloidosis, of course, the only current proven therapy to improve outcomes, that is improve survival and reduce heart failure hospitalizations, is tafamidis. Tafamidis, a TTR stabilizer. It does not reverse disease. It simply prevents future deposition. It stabilizes the TTR tetramer, so it does not form the fibrils that would infiltrate into the cardiac tissues. And in the ATTR ACT trial, which came out in New England Journal in 2018, we know it helps patients live longer and stay out of the hospital. Much more effective when it started earlier in the course and less symptomatic patients, likely because it does not reverse, it only stops progression. But as you noted, how do you think about other guideline-directed medical therapy in patients with cardiac amyloidosis? And it really comes down to their unique pathophysiology, because sometimes they have a preserved EF and sometimes they have a reduced EF, but they're almost always restrictive. The consequence of having a restrictive physiology is they have a fixed stroke volume, which means there's two things they don't like. They don't like a lower heart rate, because with a fixed stroke volume, they rely on their heart rate to maintain cardiac output. So beta blockers, very poorly tolerated in amyloidosis. I will avoid them at almost all costs unless absolutely needed for rate control of AFib. Number two, that fixed stroke volume means They do not tolerate afterload reduction because if you afterload reduce them, they cannot augment their stroke volume to improve their cardiac output, which is why things like the ARNIs or the ACE inhibitors, the ARBs, are often poorly tolerated. So a well-intentioned physician who treats their patient with cardiac amyloidosis with GDMT, including an ARNI ACE ARB or beta blocker, may actually be doing their patient a detriment, and they may end up with symptomatic orthostasis and acute kidney injury. So I have a low threshold to stop those agents in that situation. However, the MRAs and the SGLT2 inhibitors are a bit of a different animal. The two medicines that seem to uniquely straddle benefit in both HFpEF and HFrEF, and also likely with amyloidosis. So if I'm going to give any agents to patients, GDMT to patients with amyloidosis, it will of course be diuretics titrated to symptoms, SGLT2 inhibitor, and an MRA if their blood pressure and creatinine and potassium tolerate.
Thank you very much, Dr. Kittheson. There's no more questions in the chat. There's no more questions from me on our group. I want to give another thank you so much for accepting this invitation, and we'll be able to, we hope to be able to connect you in the future opportunities. And again, thank you so much, Dr. Kittheson.
It's my pleasure. Thank you so much for having me. Have a great day.